Assalamualaikum warahmatullahi wabarakatuh. Bismillahirrahmanirrahim. Dear students, today we will discuss the paralytic squint. The learning objectives of this lecture are: we want to know about paralytic squint, its etiology and symptoms, and we want to know how one can investigate and diagnose the case. And what are the difference between paralytic and non-paralytic squint, and what's its management. See a photograph of a middle-aged man who reported in IOPD with the complaints of sudden development of diplopia in left gaze. See the photograph. Here you can appreciate that left eye is deviated inward, means having esotropia about 15 degree. So keep in mind the scenario, and then we will discuss that how can we diagnose the type of deviation and how can we investigate and then manage this case. So a paralytic squint is the deviation of the eyes which is irregular and varies in different directions of gaze. It is caused by paralysis of extraocular muscles. So etiology may be efferent pathway is defective. Neurons may be involved, nerves are the muscles, and it occur in any age. So etiology may be the lesions of the motor nerve nucleus and its roots. There may be congenital absence of the nucleus. Inflammations, for example, encephalitis, degenerative and vascular lesions can affect the nucleus. Neoplasm or toxic factors like alcohol and toxins like diphtheritic toxins can affect the nucleus. So the lesions involving the nerve trunk may be there: trauma by direct injury to the trunk, pressure on the nerve by tumors, aneurysms, or any space occupying lesions, or there may be ischemia of the nerve or the toxic effects like alcohol. Lesions may be in the muscles, congenital absence or maldevelopment of muscle, direct injury to muscles. There may be myopathy as thyrotoxic myopathy, ocular myopathy, or myositis. But in this case, though the squint is non-concomitant, but it is not paralytic, as it is due to the involvement of the muscles. Muscles are fibrotic, so the restrictive myopathy due to muscle fibrosis, and the movements of the eyeball are restricted in the direction of in the opposite direction of the fibrotic muscle. The chief symptoms of a patient of paralytic squint is the diplopia. It is most marked in the direction of action of paralyzed muscles. Diplopia is crossed in exotropia and uncrossed in esotropia. In side-by-side diplopia, the horizontal muscle is involved, and in case of vertically acting muscles paralysis, the diplopia is higher or lower in vertical muscles, and in oblique acting muscles the false image is tilted to one side. So cross diplopia in exotropia is due to, in this picture you can appreciate that right eye is exotropic. So the left eye, which is the fixating eye or the normal eye, the image is formed on the fovea centralis of a black object. but the image on the deviating eye is formed on the temporal side of the retina. As the temporal retina projects into the nasal side, so the crossed diplopia. Here you can appreciate the red object is the false image. In case of esotropia, when the eye is deviating inward, the black object is having fixation or falling image on the fovea centralis of the left eye, and in the right eye it is falling on the nasal retina of the right eye. So the nasal retina projects temporally, that's why it is the uncrossed diplopia. How will you investigate the case of a paralytic squint? In the first case, take history, onset, associated illness, onset of diplopia, whether the diplopia is crossed or uncrossed, position of the eyes, having adducted or abducted, means esotropic or exotropic, position of the head, any tilt to the shoulder, or position of the face, it is turned towards right or left. Ocular movements may be restricted in case where in the action of the paralyzed muscle. And do the second cover test. In cover test, you will find that the secondary deviation is more than the primary. Now we will discuss one by one. See the photograph of a middle-aged man who presented in IOPD. In this case, you can appreciate that eye is deviated inward and the corneal reflection is on the pupillary border, outer pupillary border. So about 15 degree of primary deviation is there in the left eye. So compensatory mechanisms to compensate the diplopia in children are sensory adaptation. And the sensory adaptation is the suppression. It is mainly in children having active neglect of vision in the squinting eye. So practically only one eye is seeing, that is the non-squinting eye. So due to this suppression, strabismic amblyopia develop in the deviating eye. But in later on, there may be abnormal retinal correspondence, that is, retinal elements of the deviating eye assume an abnormal relationship with the fovea or other areas of the non-squinting eye, so that a crude binocular single vision is attained in children, but that is usually in case where there is a microtropia. And the motor adaptation is to compensate the diplopia. Here is the face turn when the horizontal muscle is involved. Say if the lateral rectus is involved of right eye, face will be turned towards right side. If the lateral rectus of the left eye is involved, face will be turned to the left side. But head tilt is due to the oblique. Here you can appreciate that this young boy is tilting his shoulder, tilting his head towards left shoulder. It is due to the superior oblique paralysis of the right eye. As the superior oblique intorts the eye, so the patient tilt his head towards opposite shoulder to compensate this. So the diplopia is compensated. Here we do the extraocular movements in case of paralytic squint. The uppermost picture shows the normal movements. In case of lower picture, a mild restriction of movements in dextroversion. And in case of third, fourth, and last picture, gradually less and less movement of the eye. And in last picture, it means the complete paralysis, and others is the paresis. We perform the cover test. We cover the fixating eye and note that is there any movement of deviating eye. It cannot move to take up the fixation as the muscle is paralyzed. So the primary deviation remain as such. Then we uncover and observe the same eye, that is the fixating eye. Under cover, it was deviated more than the primary deviation of the paralytic eye. It is due to the Hering's law of equal innervation of yoke muscles. As when we cover the normal eye, the eye which is deviating inward in our scenario, in which there was the left lateral rectus palsy, so more and more innervation will flow to the left lateral rectus, and the same innervation will flow to the yoke muscles of other eye, that is the right medial rectus. So right eye will deviate inward much more than the primary deviation under the cover. Once we will remove the cover, it will take up the fixation abruptly. In case of paralytic squint, there is false orientation. Here in this picture, you can appreciate that the right eye is deviating inward due to the paralysis of the right lateral rectus. So when when we force the right eye to see the object and other eye is closed and ask the patient to point out this object, his finger will project much more uh, towards right side of the object, as the object will have fixation on the nasal retina, and the nasal retina projects towards temporal side. So due to this false orientation, confusion is created and patient is having problems. Here we will discuss the laws of ocular motility in a case of paralytic squint. Agonist is the muscle which causes a particular movement to one eye, and antagonist is the muscle in the same eye which is relaxing at that very moment. So this movement of this agonist and antagonist are governed by the Sherrington's law of reciprocal innervation. Increased innervation to a given extraocular muscle is accompanied by reciprocal decreased innervation to its antagonist. And the yoke muscles are one in each eye. When one muscle is acting and having a particular movement of that eye, say in this picture, you can appreciate that the lateral rectus of left eye and the medial rectus of the right eye taking the eyes towards left side, that is the levo version. So the left lateral rectus and the right medial rectus are the yoke muscles. So equal and simultaneous innervation is flowing to the yoke muscles. So in case of paralytic squint, secondary deviation is more than the primary deviation. In this picture, you can appreciate that due to paralysis of the left lateral rectus, the eye is deviated inward. So this is called primary deviation. But if you cover the right eye and force the left eye to fixate, as it cannot move towards left side, more and more impulses will flow to the left lateral rectus, and due to Hering's law of equal innervation, same impulses are flowing towards right medial rectus. So right eye will be deviated much more under the cover as compared to the primary deviation. So that's why the secondary deviation is always more than the primary in case of paralytic squint. So we to chart out diplopia, we have a Worth 4-dot test. Here, patient is wearing a red-green goggles and he is asked to see on the illuminated vision box where 4 dots are present. 2 green, 1 red and 1 white. If the patient is normal, he can see all the 4 dots, 2 green, 1 red and fourth one a mixture of red and green. But if we see only 2 red circles, it means left eyes in suppression. If he sees 3 green dots, it means right eye is in suppression. If it sees 3 greens and 2 red circles, it means he is having diplopia. This is the diplopia charting with red and green goggles. A diplopia chart for right lateral rectus palsy. In this case, you can appreciate that a line, this green line, this green oblique line, right side, towards right side, patient is experiencing diplopia, and on its left side is the single vision. So when the horizontal muscle is involved, there is more separation of the 2 images in the horizontal direction. When the have any extraocular muscle is paralyzed, the ultimate sequelae of other muscles is that with the passage of time, there is overaction of, initially there is overaction of contralateral synergist, contracture of the direct antagonist in the same eye, and the secondary inhibitional palsy of the contralateral agonist of the other eye. We can elaborate this with the example of right lateral rectus palsy. In case of right lateral rectus palsy, there is overaction of left medial rectus, and there is contracture of right medial rectus, that is the direct antagonist of the right lateral rectus, and there is secondary palsy of the left lateral rectus, that is the contralateral antagonist. There is ultimately changes occur in the muscles as we have mentioned previously, and the same changes denotes on the Hess screen. When there is a stable Hess chart, it means there is no more further progress, and then we embark upon the surgery for the paralytic squint. Otherwise, we do the conservative treatment. Now we will discuss the difference between paralytic and non-paralytic squint. The incidence of the squint in paralytic case it is usually in the adults, and in case of non-paralytic squint or concomitant squint, it is usually in the children. Etiology of paralytic squint is usually the afferent pathways involved, but in case of concomitant squint, afferent pathway and the centers are defective. As far as symptoms are concerned, diplopia, false orientation, vertigo, abnormal position of head or face is there in case of paralytic squint, but there are no symptoms such present in the concomitant squint. Only the cosmetic defect which is pointed out by parents, relatives, or the friends. As far as signs are concerned, in case of paralytic squint, there is a restriction of extraocular movements in the direction of paralyzed muscle. And secondary deviation is always more than the primary. But in case of concomitant squint, there is no restriction of extraocular movements, and primary and secondary deviations are always equal. As far as investigations are concerned, in case of paralytic squint, we see the extraocular movements restriction. We do the cover test, we do diplopia charting, Worth 4 dot test, Hess screening, and ultimately we measure and have exercise with the synaptophore. But in case of concomitant squint, there is no restriction of extraocular movements. So primary or secondary deviations are normal in case of cover test. And with synaptophore, we can exactly measure the deviation and also give the exercise to the patient. As far as treatment is concerned, in case of paralytic squint, we always first tackle the diplopia, then we treat the basic cause of the paralysis of the nerve, and we do the surgery when Hess chart is stable. And in case of concomitant squint, always refraction, and that too cycloplegic refraction is must, and we give the full correction of the refractive errors. And then we treat the amblyopia, as in case of concomitant squint, it is usually in the children, so the chances of amblyopia are there. We treat the amblyopia by occlusion of the healthy eye. We give the orthoptic exercises and then wait for recovery. And ultimately, the leftover squint is treated by the surgery. We treat the underlying cause, as the nerve paralysis may be due to ischemic causes. The diseases involved are usually diabetes, hypertension, lipid derangements, anemias, etc. We cater for these diseases, and usually in patients which are of older age group, they are usually recovered within 3 to 4 months. But in case of younger patients, we always do the MRI or CT scan, or in those patients who does not recover in 3 to 4 months, we do the CT scan or MRI. And if we found any underlying cause like space occupying lesion, tumor, aneurysms, we treat the cause. We can treat the diplopia by patching the healthy eye or the involved eye, or we can treat the diplopia by the botulinum toxin injection, that is called the chemodenervation. And the indications of botulinum toxin chemodenervation are to determine the risk of post-operative diplopia, to assess the potential for binocular single vision, to give symptomatic relief during recovery, or with the patient having poor cosmetic deviation. And the principles of botulinum toxin chemodenervation is, here you can appreciate that the left lateral rectus is involved. We can give the botulinum toxin in the left medial rectus, that is the antagonist of the left lateral rectus. So comparatively, we also paralyzed the left medial rectus so that I take up the fixation, or it is corrected somewhat, so the diplopia is treated. In this picture, you can appreciate the two types of procedures. In Hummelshim procedures, we divide the here we have tackled for later rectus palsy. We divide the superior rectus in two portions and inferior rectus, then insert one portion to the later rectus. It will strengthen the paralyzed muscle, that is the later rectus. In case of Jensen procedure, we divide the belly of the superior rectus and inferior rectus and tied it with the part of later rectus. So by this method, the later rectus is strengthened. That is all, dear students, about the paralytic squint. And here I am giving you the assignment to complete and respond on WhatsApp number given or the email given same day as soon as possible. And your attendance will be marked on the basis of your response. Thank you very much, ladies and gentlemen, for patient listening. Thank you very much. Please.